Hello and welcome to today's webcast, brought to you by the Center on Knowledge Translation for Disability and Rehabilitation Research, or KTDRR, at American Institutes for Research. The Center on KTDRR is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, known as NIDLR, in the U.S. Department of U.S. Department of Health and Human Services, Administration for Community Living. I'm Joanne Starks with the Austin Office of American Institutes for Research, or AIR. I also want to thank some of my colleagues who are helping with today's event, Ann Outlaw and Stephen Boydston. Just a reminder, the webcast today is being recorded so we can make the archive available for later viewing. Most people confirm they are okay with being recorded, but if you do not want to be recorded, be sure you do not make any comments or ask any questions in the chat box. In this webcast, Dr. Marcel Dykers will share information and lead a discussion on the limits of evidence-based practice, especially when an intervention is not implemented exactly or with the same population in the same context as it was developed. This is a topic of interest that was identified by members of the community of practice on evidence in disability and rehabilitation research. Before we start, I want to point out that we do have CART services available. The link is posted in the lower right-hand corner of the screen. Next, I'll review some basic features of the Adobe Connect platform. You should be listening to the presentation through your computer speakers. To increase the volume, you can use your own computer audio settings. There's also a speaker icon in the control bar at the top left-hand side of the screen. This icon is green when it is active. You can also adjust the volume using the arrow next to the speaker icon. The presentation slides are in the center of the screen. On the bottom right side is a box labeled Links. You can browse to the link for CART services. You can visit the webcast page where you can download a PDF file, or if you prefer, a text file of the slides. The slides on the computer screen are small, so having the file or a printout could be helpful. On the left side of the screen, you'll find the chat box. If you have any questions or would like to make a comment, please type into the chat box and I'll read your question aloud. Please feel free to ask a question at any time during the presentation. And you can also let us know if you have technical issues and we'll try to help you out. Now I'd like to introduce the facilitator, Dr. Marcel Dykers, who also serves as leader of the Center on KTDRR's Community of Practice on Evidence in Disability and Rehabilitation Research. Dr. Dykers is research professor in the Department of Rehabilitation Medicine and a senior investigator in the Brain Injury Research Center at Icahn School of Medicine at Mount Sinai. Thanks, everyone. Now let's get started. Marcel?
Thank you, Joanne, and good afternoon, everyone. I hope to get a lot of input from a lot of people today. I prepared some slides mostly to get you thinking about the issue. The original question asked by somebody, or the issue suggested by somebody quite a few moons ago, a member of the community of practice, was indeed, can we still call it evidence-based practice if we deviate from the evidence? But I widened the question a bit by essentially saying, what evidence? Because very often we get very little information on what the evidence is. We all know that presumably the best evidence for evidence-based practice comes from systematic reviews, which ideally are developed using a PICO question, population intervention comparator and outcome, sometimes extended to T time point of the outcomes, and as the setting. So I grabbed a random, recently published systematic review from the literature, Ravi and Kumar and Singhi, effectiveness of virtual reality rehab for cerebral palsy. And you see here what the authors hope to achieve, updating and summarizing the current literature. They expected that what they reported would be useful to optimize approaches in clinical practice. They specified that they conducted the systematic review using Prisma, and my SIG there indicates that Prisma is not instructions on how to conduct a systematic review. It's how to report a systematic review. And they said they weren't getting into meta-analysis. So they had the PICO question, the participants, the intervention, the control, which was either a control condition of the subjects at baseline or a control group that then presumably didn't get the virtual reality intervention. And the outcomes, they essentially looked at everything in the ICF. For each one of the 31 papers they reported, they gave information on what's in blue. What was the device? What type of virtual reality was this? Non-immersive, semi-immersive, or immersive? What was the input device? What was the output device? How long did sessions last? How many sessions per week? And total number of sessions. And in red here, I took the information that the authors reported for one study they used, the Silva 2015, who used the Xbox Kinect, which they designated as non-immersive. Input was by way of the Wii balance board and a remote. There was no output device. Sessions 3 times a week for 30 minutes, total of 40 sessions. So we got that type of information for 31 papers. Results with respect to body structure and function, 10 studies found improvement in balance. Maybe the ones that use the Wii or the Kinect, a little bit more. 12 studies found improvement in upper extremity skills, but 8 found no change. 2 studies, improvement in lower extremity function and gait, but 2 didn't. 3 of 4 found improvement in overall motor function. Activity and participation, it was reported so infrequently, and no clear improvements were reported. Personal factors, no clear. So pretty much this is the results of the systematic review. So aside from the fact that you have to say, well, is there support for virtual reality, or are there so many studies that fail to find it that we should doubt it? But even if you say, hey, virtual reality is great, what exactly are you supposed to do? And that is not reported. And pretty much, if you look at what Prisma tells you, that you should report on study characteristics, you need to present characteristics for which data are extracted, study size, PICO questions, follow-up period, and provide the citations. And with respect to the results of individual outcomes, yeah, present for each study a simple summary data for each intervention group, effect estimates, and confidence intervals, ideally with a forest plot. So it's not that the authors of this particular systematic review deviated from what Prisma suggested be done. They pretty much did what Prisma suggested there to be done, but essentially, as a clinician, you get almost no information as to, well, what am I supposed to do? How many minutes a week? How many sessions a week? Should I use the Wii or the ConnectBox X? And specifically, what programs, apps, etc., should I be running to improve the patients? Now the question is, the systematic reviews tend to spend a lot of time on describing how they found and evaluated the evidence and very little on presenting the evidence. Do we get more if we go to the primary studies? And do they provide more information on the patient sample, their age, their impairments, their activity limitations, the comorbidities, etc.? Do we get more information on what was done, who provided it, how, where, when, how much of it was given, whether there was any tailoring of the intervention or in response to individual patient characteristics? What were the outcomes and when were they administered? And if we follow such reporting guidelines as TIDIR, and I hope everybody is familiar with that term. It's an abbreviation for Template for Intervention, Description, and Replication. You indeed get fairly extensive instructions as to what you need to report as a result of doing your primary study. You should provide what information, what materials, what procedures, and I'll leave it to you to scan this for more details. You have to report on who provided it and what was their expertise, their background, their generic and specific training, how was it delivered, modes of delivery, where was it delivered, locations, etc., etc. So, and then TIDIR, wants you to provide information on a dose. When was it delivered over the course of treatment or timing since injury onset, something like that. How much was delivered? Intensity, dose, etc. And then the tailoring, was it one size fits all treatment or was it individualized? So we have the issue that what supposedly is the best evidence is a systematic review, and we have seen how limited the actual information and recommendations for treatment are after a systematic review. And the problem here may be that the whole idea for systematic reviews came from medicine, and it came from summarizing studies that evaluated drugs for particular medical illnesses. Well, for a drug, it's very simple to specify what the treatment is and what the dose is. Yeah, you just have a generic drug name or a specific brand name, and you have milligrams, numbers of time a day, and maybe something like milligrams per kilo body weight. But the story becomes completely different when you're talking about rehabilitation interventions. Yeah, what all of you administer or study or regulate is what typically is called um, complex interventions. Yeah. And you cannot give a prescription with the one-liner that a physician can do it. Yeah. So even in medicine, the systematic review may be supplemented with a meta-analysis may work and may give you some very clear information on what to do for what subgroups of patients, period. For complex of interventions, it's more difficult, and let's take a typical systematic review in the rehabilitation arena. They generalize over 2 to 20 studies, sometimes more. The example in this case had 31. And all of them have somewhat unique inclusion-exclusion criteria, variations on the intervention, the duration, the total hours, the specific components in a complex intervention, the usual the control group or the comparator group may be different in these 2 to 20 studies, from a controlled comparator to usual care, waitlist control, those kind of things. The outcomes considered may be somewhat different, and even if they have the same outcome, the various studies may still use different instruments to operationalize it. The timing may be different in the various studies, and the settings may be somewhat different. So, and if you get all of that in a summary that is as sparse as we saw before in this particular physiotherapy study, you have little to go on. And even if your evidence is a primary study, which may take 2 or 3 pages to describe the intervention and the outcome measures and what was measured where and what the group that was treated consisted of, even if that is a very clear description, when you as a clinician need to apply it in your patients, or if you as a researcher want to do a replication study or want to study some twist on this, you still need to do some whether you want to call it adjusting, tweaking, individualizing, for your local resources available, the patients, the staff capabilities, and of course, staff patient priorities and preferences, which we have agreed is a very valuable component to evidence-based practice. Which leads us to the question, well, if you change the evidence, the population from what the primary study or maybe the secondary studies said it was, or you change the intervention, or you consider outcomes that were not exactly included in the systematic review or the primary study, or you're interested in time points not considered, and we know that many studies only consider outcomes pretty soon after treatment ends, and we don't find out much about how good was this intervention in terms of keeping these patients better functioning 2 years later rather than 2 days later. If you change all of these things or some of these things, do we still have evidence-based practice? Are we still basing ourselves on the evidence? So the general questions are, one, do you, in a primary study or more suspect in a secondary study, a systematic review, get enough information on what the intervention is and how it works for what groups of patients in terms of which outcomes when, and you apply that, do you get the information? If you have to tweak it, can you still call your practice evidence-based? And if you say, well, it depends on what you are tweaking, what you are changing from the evidence, does it depend on whether you are still evidence-based or not? If you change the nature of the patients, the quantity, quality, timing, or nature of the intervention, if you shoot for different outcomes or outcomes at different times or some other factors. So there is the questions, and I am looking forward to getting people's opinions, what they think about this, and how they, if they agree or disagree with what you may have heard my stance may be. What is your justification? So you can address with your comments one of the discussion questions or something else. You can add questions, whatever you want to contribute to this discussion, please. And you can speak up, and you can type your question in the box on the lower left-hand side, and I will read it there, repeat it for the entire group, and if I have an opinion.
We do have a comment. We have a comment from Debbie and Joy. Part of evidence-based practice includes the expert utilizing the evidence in an appropriate fashion using their clinical expertise.
Yes. well, generally it's phrased, combination of the evidence and expertise. Presumably, the expertise is to consider the need to change the evidence. So I am not saying that nobody ever ought to deviate from the evidence, but the question is, well, where do you stop being evidence-based and you are essentially freelancing, and where is it still reasonable to argue that, yes, you are based on the evidence, although you are making some modifications in light of the needs of the patient in front of you and or local resources and some other things. So I doubted that anybody who is supporting the idea of evidence-based practice wants to throw out completely the expertise of the people who have to do evidence-based practice. We may have had defense of that stance 20 years ago when evidence-based practice was first, quote unquote, discovered. And people in derogatory terms started to talk about cookbook medicine and cookbook physical therapy. We fully well realize that human beings are not meals you put on the table. They're much more complex, and therefore the evidence has to be applied in a setting that takes the person's characteristics and the person's preferences, etc., into account, but yet...
We do have some more questions coming up over here, Marcel. We're starting to get a list. I don't know. Can you see them?
I don't see them. That's the
okay.
issue. There they come.
Well,
okay.
Yeah. So Linda, I think, was the next question after Joy and Debbie. So if you can see that one, I'll let you read it, or I can read it.
The tidier tool.
It's before that one.
Before.
Think, right? Yeah, she had two questions. The first one is, so what are your suggestions regarding the available evidence and how we can use? Systems are different considering geographical location, unique characteristics of your population within the population of study. How do we do this? Which is kind of what you were just talking about. And then her next question is about the tidier.
Okay, so the first question, I not necessarily have thought this through enough in all its ramifications to offer you a line in the sand saying, this much you can change, and if you change 1 iota more, you are not evidence-based anymore, and we will kick you off the island. It's presumably not that simple, and I am not aware whether anybody has done any systematic study where they say took an treatment that was solidly evidence-based and implemented it for one sample without any change, and for another sample with a little bit changed intervention, and for the third one with a little bit changed group of patients, and the fourth one with a change in the group of patients and the intervention, and looked at the outcomes. If somebody is aware of studies like that, I would very much like to hear from you. Sometimes in meta-analysis, this is done when a sensitivity analysis or a subgroup analysis is performed, and the effect sizes are compared for studies that use 10 to 20 milligrams and studies that use 25 to 50 milligrams, or something like that. Again, with medicine, it's fairly straightforward. With complex interventions, there are potentially so many things that you can twist and tweak. It presumably would be much harder to do a study as I suggested and come up with clear conclusions. So I don't have the answer. I'm not necessarily saying there is an answer, but it might be worthwhile for all of those on this call, and maybe your professional organizations to give some attention to this idea. Everybody is jumping on the bandwagon. We do evidence-based medicine. Well, when does it stop to be evidence-based? So, Linda, I hope that's some useful things to consider. As for Tidier, Tidier is directed to the people who report primary studies, intervention studies. It was developed by a group in Europe with heavy English majority. They may have been all English, published about 3 years ago. And essentially, they are a guideline for reporting with 11 items that they say you ought to report this and you ought to report that. And like is the case with these reporting guidelines, they offer justification why it's important, and they offer examples of how to do it. You are linking this to my system. Well, I'm not sure that I am offering a system. I am asking a bunch of questions. But if you are addressing such issues, as well, if we had a number of different studies, all of which presumably are based on the same evidence, where can we try to determine where any differences in outcomes result from? Comparing these studies might be a lot easier if all of them did their reporting in terms of tidier. The fidelity of the intervention is just one item, and of course, if we set out to test an hypothesis that treatment X is good for outcome Y, and we operationalize treatment X in a number of sessions with a number of steps to be taken, etc., then we would like to know that the actual implementation of this study indeed yields pretty close to the protocol, and there's where your treatment fidelity comes in. But you could even imagine a study where a brilliant therapist on the fly cooks up a treatment for a unique patient with a unique problem, and afterward writes a case study and follows tidier to specify what was done. So in a case like that, we would not have fidelity issues, but tidier would still be of potential benefit, use, etc., etc. Ronnie Dietrich.
So we have, you see Ronnie's question? Okay.
It seems like practitioners will always have to make inferential leaps from the evidence to a particular situation. How large a leap is acceptable is the question, and I agree with you. That's the question, and I may have give some suggestions as to along what dimensions you can differentiate from the evidence, but in the end it's the same story. So Linda, great question. I assume she's talking to Ronnie. What are the alternatives to evidence-based practice? Well, we could go back to what the situation used to be, which pretty much was clinicians were trained in school, got a little bit information about research, then started practicing and either had their own subscription or their hospital had a subscription to some journals, and on a rainy day or when a patient wouldn't show, they would start leafing through the journal and, oh, here's an interesting article, and they might or might not be convinced that what was described was a good treatment, and they might or might not apply it, and nobody would claim that they were doing evidence-based practice. They probably would tell you that they would apply what they learned in school and from their mentors when they were just starting out their professional life. So there were people, and there still are people that pretty much trash evidence-based practice as undoable, not good for the patient, cookbook, etc., etc. But most people and most professional organizations are agreeing that yes, we ought to base our treatments on the evidence, and we ought to be in the business of evidence-based psychology and evidence-based physical therapy and evidence-based what have you. But that not
I think Joy's
necessarily-
Joy's question fits with that.
Okay.
For instance, if there's a study in people with stroke who have the same impairments as someone with MS, I might choose to use that evidence to guide my intervention in the person with MS. Is that still evidence-based practice? I think perhaps the way a population is defined is an important variable. Is the population defined based on the diagnoses, stroke versus MS, or in terms of the impairment or functional deficits?
Great question. If you are aware with some of the stuff that's being done in evidence-based approaches, especially, say, the GRADE approach, GRADE, they judge the evidence and make a distinction between direct evidence and indirect evidence. And if the systematic review wants to collate information on how best to treat people with MS, they may take in some evidence on people with stroke and call that indirect evidence, and indirect evidence never counts as much. So here is where clinical expertise comes in. Can you extend what has been learned from stroke to, say, traumatic brain injury? And an even prettier question, I think, is, well, should we go with the diagnosis, or should we go with the similarity of the impairment that is shared between those two diagnostic groups? And they're very much, I would say, the clinical expertise comes in, and where I, as a pure researcher, always have to step back and say, well, it's up to you, topic area experts, to determine whether this indirect evidence has any value, and if so, how much value it does have. So, what I've said and what my slide said about difference in diagnosis, indeed for somebody in rehabilitation might be based potentially better on the impairment, functional shortcoming that a patient has, and that the patients in the evidence base have.
We've got a lot of questions coming up and only about 15 minutes left here. So, Jenny,
okay.
Another challenge is that the intervention dose provided in the research may not be feasible in clinical practice. For example, not reimbursed at the dose, not feasible for the patient, clinic, etc. For example, if treatment is provided in the research study at 5 times a week for 1-hour sessions across several studies, this would be very difficult to translate into most clinics for many reasons. Is it reasonable to provide a dose that is as close as possible to the research?
Yep, similar studies, similar questions. We know that research studies, especially if they are supported by a grant, very often have the option, the resources, the financial feasibility to offer many more treatment sessions and richer treatment sessions than the poor clinicians in the trenches. So you have to cut back. Very often you are boxed in by what the third-party payer will pay for. What is it? 10 occupational therapy sessions under Medicare per year. Blue Cross, maybe 15 sessions with a psychologist. I do not blame anybody for grabbing the opportunity to deliver what you can, but you indeed have to ask yourself, am I still evidence-based? Which also brings back a very valuable question to the researchers among us. Well, rather than studying what is optimal, maybe we should studying a dose that is feasible, practice-based, and see whether we can create and deliver in those 8 sessions or 10 sessions something that still has value to the patient. Okay, Joanne provided you with a link to the TIDR guideline itself, which then has a link to the article that presented it. Ronnie, if we think of evidence-based practice as a decision-making process rather than a list of interventions, then we can make inferential leaps as long as we are clear that we are sometimes making large leaps, and we should engage in more comprehensive progress monitoring. Well, you know what a good physical therapist I am, Ronnie. And if you published a systematic review that showed that treatment X applied to patients with stroke in 20 sessions relieved their knee pain, and now I am reading that and I say, well, I can't do treatment X because I'm not smart enough, but Y, treatment Y, looks somewhat to it, and my patients are not stroke, they're multiple sclerosis, and their problem is not knee pain, it's neuropathic pain. I am making big leaps. Is anybody going to grant me the soothing idea that I'm practicing evidence-based practice? So, I'm not sure that being aware that you are making inferential leaps, whether small or large, resolves the basic issue. Okay, Joy Williams brings up Sarah Callahan also here with Joy and Debbie Backus. I think these dilemmas point toward the importance of practice-based evidence. We probably don't know, to Jenny's question, if approximating the dosage done in a recent study will provide the same benefits. But we should be critically evaluating our treatment effect, sharing findings, and constantly seeking additional evidence that can inform our interventions. I agree with you, Ronnie, on progress monitoring. Okay, I have no problem with that. And everybody and his brother is encouraging that we should base our knowledge more on evidence that comes out of regular routine practice than out of research with all their artificiality. The question is, how can you do it? And some of you, all of you, many of you may be aware of a series of studies that were done in the last 10 years or so called the evidence-based practice studies. There was the first one in stroke, then joint replacement, then spinal cord injury, and then traumatic brain injury. And in those studies, we had therapists, after each treatment session, fill out a form on which they summarized what was being done in that session. It was a major undertaking to have 60, up to 60 therapists in each of 8 or 10 or 14 different sites complete the same form, and that was just for unquote short-term, 2 years data collection, I think, study. It's a major undertaking to have clinicians collect data in a way that can be changed not just within an institution but across institutions. And I would love to see it. I would love to have it, but it's not that easily done. There are hopes for electronic medical records that they become more useful to clinicians, to rehab therapists, and we can have more common formats across clinical centers in what people write down so that we can use that information. So keep it up, keep trying, but it's not going to be that simple.
Let me go ahead and see what Jenny wrote down. She was responding to Joy and Debbie. We should collect this information, especially since we don't know the ideal dose for our interventions. Use of a core set of measurements and analyzing this data would help. And Joy, at the same time, wrote, I agree, and this supports the need for implementing standardized outcome measurement in clinical practice. And then Ronnie follows up with, I agree that practice-based evidence is the ultimate criterion of the appropriateness of our inferential leaps.
Well, let me first focus on Jenny and Joy. Yes, we would start at least the journey towards analyzable clinical data collected as part of routine care if we indeed had an agreement on outcome data that were collected by therapists in the same discipline and maybe across all patient diagnostic groups or for the diagnostic groups. And there's a number of efforts that are being taken by professional organizations, special interest groups, and a number of other people with an interest in a stake in evidence-based practice. But I would be very surprised if we asked 50 clinicians to report to us on the outcomes measures they are using, that many of them would even use any standardized outcome measures, and if they do, that they would use the same ones, or that there almost would be as many outcome measures used as there are clinicians. So we have more work to do to get us on the road to truly useful clinician-provided outcomes data that can be used as a basis for evidence.
Linda shared the AIRQ Innovation Exchange link with us as an interesting link to review evidence and practice. And then we had a question or a comment from Susan responding to Jenny. Agree that you adapt the intervention to clinical situation as best as possible, but still collect outcomes as similar to the efficacy study so we can understand the effects, for example, modified CIMT. Interestingly, some interventions adapted, producing almost as strong an effect.
True, both for CIMT and for others, and that may be because the people who invented CIMT got themselves on some side roads or did not maximally understand the more basic science evidence and how it could be applied, etc., etc. Claims data generally are so poor in any information, both in terms of the what was done to and for the patient and what were the outcomes, that you may not find much of anything beneficial in mining them. The other things, electronic medical records, that's indeed where I see the most hope, because everybody, when a treatment session is over, goes to their computer and puts some information in. So if the computer pops up a menu and says, okay, from this menu pick the 4 or 5 things you did for the patient, and pick here the outcomes that you achieved. Is there a standardized outcome measure? Click on it and put in the information. It would be close to painless to provide the information, and if we all can agree that either we all use Epic or whatever the electronic medical record system is, they can talk to one another and translate what they have back and forth, we should be getting closer to the evidence that is based on actual daily practice rather than the sometimes artificial research.
This is Joanne, and sorry to interrupt, but we have come to the top of the hour. Our CART captioner has to leave, so we should probably go ahead and wrap up, but we probably can take a couple minutes to finish up today. We do have a few more comments over in the side here if we can. I don't think we have time to address them all, but it's good fodder for a future discussion.
Let's do that. It's 4 o'clock, and people need to go to next things, other things. We have these pieces of information, the questions, and we certainly can see whether any of your additional questions and suggestions open up venues for continuing this discussion the next time around. Yeah, I certainly believe that there is more to be said, much more to be said. So for now, we will harvest everything that people have said, look at it, and make a decision about how and when to have a next session. For now, thank you for your attention. My apologies for the phone running away. Thank God I managed to come back fairly easily, and Joanne, as usual, was a great stand-in. So thank you, Joanne. Thank you, Anne, and the other people at AIR, and we'll be talking probably in a month to 2 months. Thanks again.
Okay, well, thank you very much, Marcel, for sharing this information and leading this discussion. We hope you can take a few minutes to give us some feedback about the webcast by filling out the brief evaluation. It's here on this last slide. And we'll also send out an email with the evaluation link to everyone who did register. Thanks again for coming today. I want to thank the AAR staff that helped with planning and logistics. And of course, we want to thank NIDLR for their support to offer these webcasts and other events. We thank you for joining us for the webcast today, and we look forward to seeing you for the next Center on KTDRR's event. This will be probably our 2017 online KT conference coming up on October 30th, November 1st, and November 3rd. Registration is open. Please visit our website at www.ktdrr.org for the details. Good afternoon, everyone.